All right, well, we are starting a couple minutes late here because of the joys of technology. So we're going to get going, and there may be some people that continue to join us over the next few minutes. So hello, participants, and thank you so much for joining us today for our virtual webinar event. My name is Molly O'Brien, and I'm the Chief Strategy Officer at the Minnesota North Dakota chapter of the Alzheimer's Association. And I so wish that we were together in person and I could see all of your beautiful faces. I'm hopeful that will happen soon. So the purpose of this webinar series is to provide an overview of this public health crisis. Number one, we'll frame dementia disparities as a national problem. And in a future webinar, we'll begin to explore local opportunities to improve dementia detection, diagnosis, and care. So today, our National Alzheimer's Association leaders will ground you in the human impact, economic impact, and disproportionate impact of Alzheimer's and other forms of dementia. And then in future webinars, we will explore emerging solutions together. So for those of you who aren't familiar with the Alzheimer's Association, I just want to ground you in our mission and our vision. So our vision is a world without Alzheimer's and other forms of dementia. And our mission is to lead the way to end Alzheimer's and all dementia by accelerating global research, driving risk reduction and early detection, and maximizing quality care and support. A little bit about what we do. We provide free care consultations, community education, support groups, and a 24/7 helpline in over 200 languages. We train healthcare professionals and work with health systems around early detection and diagnosis and care. We develop and advance policies to overcome Alzheimer's disease through increased investment in research, enhanced care, and improved support. And we are also the largest nonprofit funder of Alzheimer's research. We're committed to accelerating the global process of new treatments, preventions, and ultimately, someday, a cure. I can't really start today without thanking you for showing up when there's so much happening in our communities, so much unfolding. We're obviously in the midst of a pandemic. We are grappling with hate, racial injustice, pervasive gun violence, unrest, and the recent police shootings of George Floyd, Dante Wright, and Adam Toledo. Recent police killings. We're also listening to closing arguments in the Chauvin trial. We'll be awaiting jury deliberation and a verdict. So our tensions are high, our hearts are heavy, and our souls, I hope, are hopeful. So our topic of addressing dementia disparities is so timely. This disease takes a bigger toll in our BIPOC community, who are more likely to develop the disease, more likely to be diagnosed at a later stage, and less likely to receive quality care. So I'm delighted to introduce two leaders from our national office. First, Dr. Carl Hill, who is our Chief Diversity, Equity, and Inclusion Officer for the Alzheimer's Association. Dr. Hill oversees our strategic initiatives to strengthen the association's outreach to all populations and develops cross-functional partnerships with organizations to advance diversity, equity, and inclusion. Dr. Hill previously served as the association's VP of Scientific Engagement, and prior to the association, he served as the director of the Office of Special Populations at the National Institute on Aging. Dr. Hill earned his PhD from the University of Michigan School of Public Health, where he trained with the Center for Research on Ethnicity, Culture, and Health, and the Program for Research on Black Americans. He holds a master's degree in public health from Morehouse School of Medicine. I'm also delighted to introduce Matthew Baumgart. Matthew Baumgart is the VP of Health Policy for the Alzheimer's Association. He leads a range of projects at the intersection of policy and programs to achieve an aggressive agenda that serves all those affected by the disease. Matthew heads up the BOLD Public Health Center of Excellence on Dementia Risk Reduction, which is funded by the CDC. He directs the association's global public health policy efforts, working in collaboration with Alzheimer's Disease International, the World Dementia Council, and the World Health Organization. Prior to joining the association, Baumgart spent nearly 20 years working in the US Senate. He earned his degree in communications with a second major in political science from Washington State University. And with that, I will turn it over to Matthew Baumgart.
Okay, all right. Well, thanks everyone. I'm excited to be here. I hope I can still be seen and heard. Really excited about today's webinar, and I'm sure I can still tee up Matthew's presentation because we have a lot of connections in terms of what we want to talk about. But excited about today's title: Human, Economic, and Disproportionate Impact of Alzheimer's and All Other Dementia. As the new Chief Equity, Diversity, and Inclusion Officer, and certainly coming from the MedSci group, this is right in line, I think, with our vision for really a world without Alzheimer's and all other dementias, and with all communities and all people. So this is really just an exciting, I think, opportunity to talk. Landscape of what we can accomplish today.
Dr. Hill.
Yes.
Matthew is back on. Let's see if we can hear from him.
Okay. Let's see.
Can you hear me?
Oh my gosh. Look at all the blessings we have today. Okay, Dr. Hill, thank you so much.
I'll stop share. There we go. Okay. All right. There you
go. I'm really glad to be here today. And again, apologies for the technical issues. I have the unenviable task of talking to you about economics, which I know for a lot of you probably was the class you tried hard to avoid when you were in school. And what my presentation on economics means is that I'm going to be throwing a lot of numbers around in the next 15 to 20 minutes. And it can sometimes be overwhelming. So I will direct you to alz.org/facts, where you will find our annual Alzheimer's disease facts and figures report. Not all, but most of the numbers that I will be using in my presentation are included in that book, and there are a lot more. It's like 80-page book, so there's a lot more figures in there than what I'm going to be using. But in case you forget something, it's all in this great publication that was just released about 3 weeks or 4 weeks ago. So let me start by just kind of giving you the top line here. Today in the United States, this year, it's estimated there are 6.2 million seniors who are living with Alzheimer's disease. 1 in 9 people age 65 and over has Alzheimer's, and 1 in 3 over the age of 85 have the disease. And this causes an enormous burden on our health and long-term care systems. In fact, back in 2013, the New England Journal of Medicine published a study that looked at the economic costs of Alzheimer's. And as the Associated Press reported, that study found that dementia was the most expensive disease in the United States. This year, it's estimated that caring for people with Alzheimer's will cost a total of $355 billion. 2/3 of that, $239 billion, will be borne by Medicare and Medicaid, so through taxpayer-supported programs, putting a burden on government health budgets. And 1 in every 5 Medicare dollars this year will be spent on somebody who is living with Alzheimer's. So Alzheimer's being that most expensive disease in America, according to New England Journal of Medicine, how is that? Because there is no treatment for Alzheimer's. There is nothing, you don't go into the hospital to get your Alzheimer's treated. There are no drug therapies that change the underlying course of the disease, at least not at the moment. So how is it that Alzheimer's is so expensive? And there are a couple of different ways, and I want to walk you through those now. So the first reason is that Alzheimer's complicates the management of other chronic conditions that an individual might have. And more than 95% of people with Alzheimer's have one or more other chronic conditions, such as diabetes or heart disease or obesity. And the mismanagement because of these other chronic conditions, because a person is cognitively impaired, or the additional management that is required often increases the healthcare costs. And this can be shown in this graph here, where you take a person with diabetes, and if a person then also has Alzheimer's, their cost to Medicare is 81% higher. Similarly, heart disease. If you have heart disease and then you have Alzheimer's on top of that, your costs to Medicare are going to be 60% higher. It is difficult to manage chronic conditions when a person is cognitively impaired. The second reason that Alzheimer's increases costs is that people with Alzheimer's have more hospitalizations. Twice as many, in fact, on average. So this graph shows that for those without Alzheimer's and other dementias, they have about 266 hospitalizations per 1,000 seniors every year, whereas those with Alzheimer's have 538 per 1,000. If you're not familiar with that stat, imagine a room and you have 1,000 people in it without Alzheimer's. 266 of them will be hospitalized. If you have a room next door with 1,000 people with Alzheimer's, 538 of them will be hospitalized in a given year. And this is borne out across those individual diseases as well. COPD, 590 hospitalizations per 1,000 seniors. You add Alzheimer's on top of it, and it goes up to 791. And you see that across multiple diseases, stroke and diabetes and cancer. In addition, almost 1 in every 4 hospitalizations among people with dementia are preventable. A preventable hospitalization has been defined by the Agency on Healthcare Research and Quality, that's AHRQ. It's a government agency that is concerned about the quality of care in our healthcare system. And they have a definition for preventable hospitalizations. And nearly 1/4 of people with Alzheimer's, their hospitalizations, 1/4 of them are preventable. And the cost to the Medicare system of these preventable hospitalizations in 2013 was $2.6 billion. That's $3.2 billion in today's dollars. But even more than preventable, because preventable is a specific definition, a lot of hospitalizations that are not defined as preventable according to that AHRQ definition are still unnecessary. Remember, people are not being admitted to the hospital for Alzheimer's. When you have an intake form or a discharge form, why did you end up in the hospital? They don't write Alzheimer's. But they're often there because of their Alzheimer's, because Alzheimer's has complicated their other chronic conditions to such a degree that they end up hospitalized. In addition, more than 1 in every 5 hospitalizations among people with dementia are 30-day readmissions. This is a key element in quality of healthcare. Quality care indicators show that you should not be readmitted to the hospital within 30 days. And so 1 in every 5 hospitalizations among people with dementia are 30-day readmissions. And overall, when you look at the average per person hospital spending over the course of a year, a senior without Alzheimer's and dementia, on average, about $3,800. But that number is about 4 times larger with seniors with with Alzheimer's and other dementias. That's the annual per person hospital spending. The third reason that Alzheimer's increases costs is that people with Alzheimer's have more emergency room visits. Hospitalizations and emergency rooms are 2 of the very most expensive parts of the healthcare system. And so when people with Alzheimer's have more hospitalizations and have more emergency room visits, that's going to escalate costs. If you look across all seniors, there are about 640 emergency department visits a year per 1,000 Medicare beneficiaries. And the numbers are not entirely comparable, which is why I'm not putting them side by side. But if you look at seniors with Alzheimer's and other dementias, the number of emergency department visits is 1,500 per 1,000 seniors. That means there's 1.5 emergency department visits per person per year on average. Think of it this way. If you have 2 people with Alzheimer's disease, between the 2 of them, they will visit the emergency room 3 times in a given year. The consequences of this escalated spending, this escalated utilization of the healthcare system, is higher costs overall. So if you look at seniors without Alzheimer's and dementia and look at their average annual per person health and long-term care costs, and In the interest of time, I did not get into long-term care costs, but they're included in these averages. On average, a senior without Alzheimer's is about $15,000 a year, but a senior with Alzheimer's will be over $52,000 a year. That's 3.5 times greater. And if you look in managed care, you'll see the same pattern holds. Now, there's some caveats here. There are not a lot of studies about spending on people with dementia in managed care, and the data is not as freely available as fee-for-service Medicare. In fact, there are only 9 studies that have been published in the literature about the costs of people with dementia in managed care. And the most recent of those was published in 2013 with data from 2011. So unfortunately, we don't have a lot of data here, but what we do have shows that the pattern holds, that seniors with Alzheimer's and other dementias cost a lot more. Specifically, looking at the cost in 2020 dollars, about $9,300 for seniors without Alzheimer's and dementia in managed care. Seniors with Alzheimer's and dementias in managed care, on average per person, it's about $19,000. Now, that's only a 2 times difference, and the previous slide showed a 3.5 time difference. So it looks like managed care, the difference is much smaller. But a couple of points to keep in mind, in addition to it being very old data and very few studies. It's also because this study looks at the cost just in the year of diagnosis. So it takes those with Alzheimer's and looks at what their costs were in the year they were diagnosed, finds a similar individual in managed care that meets the same demographics, that has the same underlying chronic conditions, except that they don't have Alzheimer's, and compares them in that single year. And that's the cost differential. So this does not take into account the bigger gap that will occur toward the end of life and in long-term care. The other thing to keep in mind is that there is evidence that there are fewer people as a percentage of the total with Alzheimer's in Medicare Advantage plans than in fee-for-service Medicare, and there's some evidence that those folks tend to be healthier than those in fee-for-service medicine, therefore keeping down the costs. But the bigger point is the same, whether you're in fee-for-service Medicare or whether you're in managed care Medicare Advantage plans, the difference in costs is big between seniors with Alzheimer's and seniors without. Now, if you look at spending by race and ethnicity, you'll see, probably not surprisingly, that the annual per person Medicare costs for people with Alzheimer's are higher, considerably among African Americans than they are among whites and Hispanics. Hispanics and whites are about the same, but African Americans have much higher costs. As you might imagine, this is not because African Americans are getting better care, it's because they have less access to care and they're getting diagnosed at a later stage of the disease. And as you'll see in a minute, when you're diagnosed can make a big difference in how much how much costs are incurred by the healthcare system once you are diagnosed. If you look at the type of service across race and ethnicity, again, you can see that spending is considerably higher, particularly on hospitalization costs among Blacks, Hispanics, and other races compared with whites. The differences are much narrower in other types of care that's provided, although whites are still lower. The one difference here that breaks the pattern is all the way at the far right, where you look at hospice care, where whites have considerably more spending than Blacks, Hispanics, and other races. And that is, again, an access issue. Hospice care is seen as a good indicator of quality care at the end of life, and the access to that care among underrepresented populations is much harder to come by. Therefore, they spend less on it, even though it is defined as better end-of-life care. So to review where we've been here in the last few slides, the reason Alzheimer's increases costs is because it complicates the management of comorbid conditions. People with Alzheimer's have more hospitalizations and they have more emergency room visits. So all three of these things lead us to make some conclusions about what's happening overall in the healthcare system. The first is that people with dementia are simply not receiving the best care, and that's exacerbated when it comes to underrepresented populations. People with dementia are not getting on the right care path after they're diagnosed, and they're not receiving a timely diagnosis. That goes for all people with dementia, but again, it's especially true for diverse populations. Now, all three of these point to ways that we can work at reducing costs and increasing the quality of care in the healthcare system for people with Alzheimer's and other dementia. And as Molly mentioned in her introduction, a future webinar is going to look at some ways from a local standpoint that you all can begin to address those issues. What I want to show you is how the savings could accrue in various ways of addressing some of these issues here. So we'll start with providing care management. So care management is a system, it's an effort really, a program to help people with dementia and their caregivers manage their care, both health and social care, and it includes the caregiver. So it's not just the patient, it's caregiver education and caregiver services. And this can reduce costs throughout the course of the disease. There have been 2 pilot programs that show the potential for ongoing care management of people with dementia. One of these was out of the University of Indiana, the Healthy Aging Brain Center program, which showed that people with dementia who went through the program had on average about $3,500 less in healthcare spending per patient per year. There was a nearly 6-to-1 return on investment. That is, for every dollar that was spent on the program of care management, there was $6 on savings on the back end in lower healthcare costs. And this was brought about by reduced hospitalizations and fewer emergency room visits. A similar program out in California at UCLA, the Alzheimer's Dementia Care Program, found similar results, about $2,400 less in per person per year spending. There was a 33% reduction in nursing home placement for those who went through this program. And while this program did not show a reduction in the number of hospitalizations among people with dementia, it did show that there was a reduced intensity of care among those hospitalized. In other words, the amount of care they needed to receive in the hospital and the length of stay in that hospital was smaller if they had gone through this care management program. Another way to provide better care is through care planning. Now, you can only manage a person's care if the person gets on the right care path at the outset. So after diagnosis, are you setting up a plan that outlines the care to come and the type of care that needs to be received? That care planning is key when it comes to chronic conditions, because care coordination and management of those other chronic conditions is really important to lay out a plan as early as possible after diagnosis. Now, there was a bill back in 2015 before Congress that looked at what would happen if Medicare covered care planning for people with dementia. That now actually is a Medicare benefit that became effective in 2017. This bill looked at what would happen if Congress passed a care planning benefit for Medicare beneficiaries with dementia, and it found that over a 10-year period, there would be $692 million in savings to the federal government. The third way to provide better care is timely diagnosis. And this economic study gets very, very complicated, so I'm going to boil it down to the simple bottom line. This line here shows the continuum of Alzheimer's. On the far left, it's preclinical Alzheimer's. That is, you have the brain changes that are associated with Alzheimer's disease, but you don't yet have any symptoms. The teal in the middle is mild cognitive impairment due to Alzheimer's. And then on the right in the gold is Alzheimer's dementia. Today, most people get diagnosed in the dementia stage of Alzheimer's disease. It occurs in various different points along that continuum, but most people get diagnosed after dementia has developed. And some people get diagnosed early. Most get diagnosed not early. And again, as we explained earlier, among racial and ethnic minorities, that diagnosis line tends to be even further to the right. But what happens, this is what this economic study looked at, what happens if you're able to move the diagnosis into the MCI stage of the disease? So not waiting to diagnose until the person has dementia, but diagnosing them when they have mild cognitive impairment. Understand what's happening to the left of that diagnosis line. Everything to the left of diagnosis, whether you're talking baseline or an earlier diagnosis, is when your care is unmanaged. You don't have a care plan and your care is not being managed because you don't have a diagnosis. And under baseline, you can see all of that time that is unmanaged. Whereas if you move diagnosis earlier to the MCI stage, there's a lot shorter period of time where you have undiagnosed Alzheimer's and a longer period of time for you to have a care plan and care management. So when this economic study looked at what would happen comparing the cost, the lifetime cumulative costs of a person from the point in the continuum where that red line is until they die. And you can see under the baseline, cumulative lifetime costs from that point, which is 1 year before the diagnosis would occur in the early diagnosis scenario, $425,000 per person. Move that diagnosis to the MCI stage and you can save $64,000 per person over the course of the lifetime. So this illustrates, I hope you've picked up, even though I've thrown a lot of numbers at you, I hope you've picked up the gist of what is happening here, that Alzheimer's is really expensive to the healthcare system through unnecessary hospitalization costs, unnecessary emergency room visits, the mismanagement of chronic conditions. But if we can get people timely diagnosed, if we can get them a care plan, and if we can get them into a care management program, then we can save money in addition to improving the quality of care. So with that, we're going to now go back to Carl. So sorry, Carl, for making you start and then stop and then start again, but I appreciate your accommodation with the technical difficulties.
Oh, absolutely, Matthew. I'm glad it worked out the way it was planned, and enjoyed your presentation. Thank you for sharing that. I will pull up my slides again here and go through this scenario again. All right. So yeah, again, and I think Matthew just did a wonderful job of laying out the case for the economic, I think, impact of Alzheimer's and other dementia, and how that could be, quite relevant for diverse, disproportionately affected populations. So I'll double down on that a little bit and really come at this to think about lifestyle and modifiable risk, give us a landscape of Alzheimer's and dementia disparities, and then some speculation around what I might call multi-level determinants. And so we'll end my 20 minutes with some speculation about a path in moving forward and pursuing health equity. So we'll take those four bullet points to start. Now, what Matthew didn't mention was his extraordinary leadership with facts and figures, and he and his team and a really impactful, I think, special report focused on race, ethnicity, and Alzheimer's in America. So please take a look at that at alz.org/facts. Matthew mentioned that one. But in our facts and figures, Matthew mentioned that there are currently more than 6 million Americans aged 65 years and over living with Alzheimer's. That number is expected to double by 2050. COVID has really shined a bright light, I think, on on the social determinants of health, if you will, and how that impacts disparities for disproportionately affected populations, many which are the same with Alzheimer's, right? Those that are more likely to be diagnosed with COVID and to die from COVID are the same populations and communities that are hardest hit by Alzheimer's. But COVID is hitting people with Alzheimer's hard, with 42,000 more deaths in 2020 than expected. That's a 16% increase there. And then disease-related costs continues to rise. Matthew mentioned up 50 billion from 2020. So however you look at this, this is a very important public health concern. Also in that facts and figures, as I mentioned, the special report on race and ethnicity is this issue of discrimination in the healthcare system. So, Matthew finished his talk with a real focus on the need for a timely diagnosis. In this special report, we found that non-white racial ethnic populations, they all reported discrimination as a barrier to Alzheimer's and dementia care. And so people of color, want healthcare providers who understand their unique experiences. Many doubt that they would have access to culturally competent providers. This really speaks to why, at least one of the reasons why individuals from these communities, may not seek a timely diagnosis or may engage one time and may never return because of being treated unfairly, right? And this also links into lack of trust and participating in clinical trials, which is so important. We'll talk about that in a minute. And so this issue of discrimination is one that really links in to Matthew's comments about receiving a diagnosis. People are feeling like they will be treated, they perceive that they will be treated unfair. And in this special report, there were actually caregivers that also reported that they had actually experienced this. So this is really critical and important. And it's primarily important because we know that there are disparities in Alzheimer's and other dementia. So almost 2/3 of Americans with Alzheimer's are women, and older Black and Hispanic or Latino Americans are disproportionately more likely to have Alzheimer's or another dementia than white. So we have disparities, and this is really important that we apply what we know about health disparities research, right? And so in a previous role where Molly mentioned, I worked with the National Institute on Aging, and we came up with a working definition, one that they use, which health disparities research is broad, right? It's encompassing. So it includes economic determinants, but also environmental, sociocultural, and behavioral determinants for understanding how we might intervene, or some of what we might call fundamental factors for intervention for health disparities research. And when we say fundamental, it is the factor that we might intervene on that would make the population level change, right? And so there's a lot of back and forth here around individual level determinants, structural or social determinants, but the concept of being fundamental means that we're hoping to intervene at the level that is most impactful, right? And so all of this kind of leads to an understanding of a pathway for risk for specific populations, and we'll talk a little bit about that now. So one of the questions that always comes up with health disparities research is, well, are there just genetic differences, biological differences between populations, between race and ethnic populations? People are just different, right? And so there was a really great presentation that was delivered during our very successful Alzheimer's Association International Conference, which was held almost this time last year. But it's successful because we had to pivot because of COVID, and it was free of charge, and we had over 30,000 participants. It's just kudos to Dr. Maria Carrillo and the MedSci team for putting that on. Looking forward to this year's AAIC. But there were some intriguing findings around the ApoE4 gene, known genetic risk factor for Alzheimer's, but primarily studied among European descended populations. And so it was found that this particular genetic risk factor may not be as relevant in this particular study for Hispanic or Latinos, and that there may be other factors, among that pathway. We talked about environmental and sociocultural factors that could be either more fundamental, right, or just more relevant for the population. And this adds to the literature in the scientific literature, which really points to social factors. You have folks like Jennifer Manley or Lisa Barnes, who are really working on disparities research in Alzheimer's, are really pointing to social factors as being really fundamental for some of the disparities that we see in Alzheimer's and other dementia. And so when we think about this, we go back to what Matthew mentioned, this continuum of cognitive impairment, and what he mentioned was that mild cognitive impairment is a known risk factor for dementia. Everyone who passes that passes through mild cognitive impairment, everyone who develops dementia passes through mild cognitive impairment, right? So we have a real opportunity to either prevent or identify, get timely diagnosis at mild cognitive impairment, to begin a treatment, a plan in the way that Matthew mentioned. So this really gives us that public health, I think, opportunity to intervene, to come up with factors that may be really important for delaying the progression of Alzheimer's or another dementia. So we have a chance here with this continuum of cognitive impairment. Another intriguing presentation that was delivered at the Alzheimer's Association International Conference showed that higher body mass index between the ages of 20 and 49 may be associated with higher late life dementia risk. Again, more research is needed here, but when I see body mass index, I think of physical activity and diet and all the things that people can do, their lifestyle or health behaviors, if you will, that could be very important for understanding or reducing dementia risk later in life, right? And so there's beginning to be this unfolding of this continuum where people pass through mild cognitive impairment to dementia, and then, well, what are some of the important factors? Well, here BMI is one. There was also another really important study, the Sprint Mind study, that showed that controlling blood pressure to 120 systolic reduced risk for MCI and dementia. So again, blood pressure, diet, physical activity, it may even link to managing stress, right? So things that people can do themselves, right? Their lifestyle and their health behaviors at an individual level could be very important. The Lancet Commission attended virtually again the Alzheimer's Association International Conference, and they added to their list of modifiable risk factors. So thinking about that continuum, what are some of the factors that are so important? In 2017, they identified education to the age of 15, or hypertension, obesity, hearing loss, depression, diabetes, physical inactivity, smoking, and low social contact as modifiable risk factors, right, for this continuum from mild cognitive impairment to Alzheimer's or another dementia. And then in 2020, just at the last AAIC, they added 3 additional risk factors, which were air pollution, so where people live and where people work, and traumatic brain injury and excessive alcohol use in older ages. So intriguing in those modifiable risk factors, from my perspective, is that some of them could be interpreted as individual lifestyle choices, but others are contextual, right? I tell you, I think about my own life and where the community where I was raised, I didn't have much of a decision about being a part of that community, and it could have been one that put me at risk with air pollution, or education to the age of 15, right? So most of us end up going to the public school that's in the community, and it may not, really supply us with what we need moving forward, and it could potentially be along this continuum of risk for Alzheimer's and dementia later in life, right? So again, we're beginning to move and think a little bit about risk and how in interpreting that health disparities research definition, how this occurs along, I think, a pathway of different factors that could put people at risk for Alzheimer's and dementia. Here's some research I think is really interesting. And so when we think of social class or socioeconomic status, there's income, money. And so Matthew talked a little bit about class and how that can afford a certain quality of dementia care. So income, education. So the Lancet Commission identified education, and then occupational status make up socioeconomic status. And here in this research by Al Hazuri and her colleagues at Columbia, among a cohort of Mexican Americans who are Hispanic Latinos disproportionately affected, she found that those which were higher SES, so had the most education, the highest quality occupation, and quite frankly, the most money, the most income, were able to stay dementia-free the longest, right? So linking in, really critically to something that Matthew mentioned in terms of having access and being of higher SES could be so very important. And we know in this country, African Americans and Latino populations, Native Americans endure lives with meager resources. So, again, social class is so very important. I always go back to when we're thinking about health disparities theory, which I think is linked, to sociology or social studies. I think about my college class at Morehouse College, and we didn't get into sociology without thinking about W.E.B. Du Bois, who was the first African American to finish a PhD at Harvard University. And he says, well, his study of crime among African Americans in this country, particularly those in the South, he says it's a symptom of wrong social conditions. So stress of life, right? He says it's something about being, to be poor is hard, but to be poor when everyone is, has many resources, is the very bottom of hardships. And so when you think about that way of thinking about people's lives and their life course in this country, and thinking about heart disease death rates. This is some older data from 93 to 2001. But as I mentioned previously, education should be a protective factor, right? And then education was identified by the Lancet Commission as being a modifiable risk factor. And so when we think about how education can work, I mean, certainly, more, maybe cognitive ability to understand important health-related information, or access to peers and networks that could be important for providing resources. So more education, right, supposed to be lower risk, right? Or more education here, better health, right? And so here, as you see, as the years of education increases, and we look at the Black-white ratio, right? And so, one is equal, right? So for men and women, the ratio increases, the difference increases by years of education, right? So this really could be interpreted in quite a few ways. This is association data, right? So this is not causal, but it does speculate something around stress in this country, or the varying value of education for some people in this country. And it really speaks for us, really understanding the course, the lived experiences, and how some of the unique pathways to risk for Alzheimer's and dementia, could be different for African Americans, for Hispanic Latinos, for rural populations, for Native Americans, for LGBTQ communities. So really, taking the time to understand how this path could be unique. Speaking of discrimination, right? And I never forget the circumstance that when we think about heart disease death rates and how more years of education leads to a higher ratio, the difference increases. What is the experience of discrimination in obtaining all these years of education, right? So
Dr. Hill,
yes,
I'm just going to give you 3 more minutes. Sorry.
Okay. Okay. So what is the experience of actually obtaining all these years of education? So this came out in some of the really compelling findings from the special report around discrimination in the healthcare system, perceived barriers to getting excellent healthcare and support. Check out our facts and figures. That was really compelling. People reported being discriminated because of their race and ethnicity. Almost half of Black Americans reported that they had actually experienced discrimination in the healthcare system. So, this concept of discrimination is so important, and it's so relevant in the way that we think about this. So when we think about lifestyle factors, things that people can do, right, in the way that the Lancet Commission mentioned, there are other factors that can influence people's lifestyle choices or their health behavior. So what we're really, tasked with understanding, is, what are some of the environmental factors that link with culture, whether there's group norms or the culture of the United States that impacts people's behaviors or lifestyle factors that ultimately influence the way that amyloid plaques and tau tangles form to cause Alzheimer's and populations that are disproportionately affected. Really, really important. So we know now when we think about the resources that people need to make their best lifestyle choices, those are important research questions. Talk about resources. We're in a golden era of research funding for Alzheimer's. And so we want to make sure that we use those resources to understand the things that people need, the resources that people need, so that they can stay Alzheimer's and dementia free the longest. This is important from a health equity perspective because we want to make sure that everyone has those resources, and we're pursuing health equity by understanding and finding ways to give people those resources. Critical because if we develop a treatment by 2025 that delays the onset of Alzheimer's by just 5 years, 5.7 people who are expected to develop this would not. We want everyone to have a chance to be a part of that number. And to be a part of that number, we need better recruitment of underrepresented populations. If you could imagine those are disproportionately affected by Alzheimer's or another dementia are the least likely to be included in the clinical trials. So the treatments, we won't know if the treatments are safe or effective if we don't do a better job of including them. Great, I'll finish here. Great presentation by Lisa Barnes that was delivered in AIC this past year. She argued for a paradigm shift. And that paradigm shift, I think, is to understand the many factors that could be unique for these populations so that we can understand how best to intervene at a fundamental level so that we can reduce these disparities and pursue the important health equity, right? And so I'll end here by saying Alzheimer's Association, that the Alzheimer's research started with Dr. Lois Alzheimer's on the left, Dr. Solomon Carter Fuller, first African-American psychiatrist in the United States. He recruited Dr. Solomon Carter Fuller to his lab. They worked together. From the very beginning, this research enterprise has championed diversity, inclusion, and equity, right? So we have a model that we must begin and we must continue to pursue to include all people in our pursuit of health equity for Alzheimer's and other dementia. And we're having a very, I think, a critical conference, June 14th through 16th, will be held virtually, free of charge. Everyone, please register and sign up, alz.org/health disparities, but we will discuss those determinants for disparities in Alzheimer's. And we'll spend the third day on the 16th talking about two understudied communities, populations, LGBTQ populations in Alzheimer's and American Indian, Alaskan Native communities in Alzheimer's. So please take the time to register and join us in June for this important discussion on addressing health disparities in Alzheimer's. And I'll end with our number and our website where a wealth of information can be found. And with that, I will kick it back over to you, Molly.
Dr. Hill and Matthew, thank you so much for really setting the table for us to understand the growing burden of this disease, the economic impact, and the disproportionate impact. Just had a couple questions pop in. Will slides be available? Will the recording be available? Yes, we will distribute those slides so that you've got those. And I think I will toss out one question that I would love both of you to answer, which is, Carl and Matthew, what role can health systems, policymakers, and public health leaders play in influencing change?
So I can start, Carl. So I think so I'm gonna try and remember the three groups. So from a public health standpoint, I think the public health community, with respect to what we've talked about today, can really promote early detection and diagnosis. That is, not only educating healthcare providers about the importance of it, but also educating the public. And I think the public health community has an important role there on early detection and diagnosis. Second of all, from a health system standpoint, I think this dementia care management is really key. I think you'll be probably delving more in depth into these types of potential solutions on the next webinar in this series. But I would just put a plug in for, I think, dementia care management programs within a health system for those who are diagnosed with dementia is critically important, not only for the quality of care, but to address the cost issue. And policymakers could adopt care management within the Medicare program. They could take steps. There's nothing to prohibit it now, but they could take steps to make it more likely that dementia care management will be adopted. Policymakers have already added the care planning benefit to Medicare, but policymakers need to promote it. The Center for Medicare and Medicaid Services needs to educate doctors that it exists. They need to educate the public that it exists, and policymakers can help fund and support those efforts. So those are just a couple of things that pop into my mind based on what we've talked about today. Of course, I have a long list of other things they could do, but trying to focus on the content of this call today.
Yeah, and I would add, Molly, just quickly, I agree with Matthew. I think, cultural competent care, cultural accountable care, so standards for delivering care that's culturally relevant, so important. Diversity within the healthcare system, so finding creative ways to partner with HBCU, historically Black colleges and universities, Hispanic serving institutions that train Asian Americans, being sure that we're strengthening those pipelines. And then the work that the association is doing, the Alzheimer's Association is doing, getting out in communities, finding ways to build that bridge of trust, to become trustworthy, so that we can do just what Matthew said, and that is let people know about the resources that are available, and they can feel comfortable. They won't feel like they will be treated unfairly or discriminated against when they access this very important and timely dementia care. Yeah.
Thank you, Carl, and thank you, Matthew, and thank you, participants, for making time for this webinar today. We will send out the invite for the next webinar, and in that webinar, we will be teeing up emerging best practices and innovations to solve this opportunity together. And that will highlight some of the work that the Alzheimer's Association is doing, and it will highlight some of the work that you are doing. Everyone have a great day and take care.